This is the lecture for Chapter 5. Today we are talking about actions of drugs. Again, talking about general, all kinds of drugs. Okay, so many drugs are chemically derived from plants. Okay, people have often asked, why do plants produce so many psychoactive drugs? Question to kind of ponder for yourself. There's a lot of people that have come up with lots of different answers. So when we talk about drugs, we talk about chemical names, generic names, and brand names. You do want to know the difference between these three. Okay? The chemical name is that complete description of the molecule, typically a word that is difficult to say, right? Okay. Then we have our generic name, which is our official legal name. Okay, it's listed in the USP, or the United States Pharmacopoeia. Okay. An example I always like to do, just Tylenol types of things. The generic name is acetaminophen, right? The generic name for Tylenol is acetaminophen. The generic name for Advil is ibuprofen. Okay. Our brand name then is that specific drug or formulation that is trademarked by a manufacturer. This is how they make money off of it, right? It's trademarked. It can be patented for over 20 years. Some are patented for less. There are some modifications that people make in order to sort of patent them for longer, but not really. Generics can come out after the patent is up, okay? So the brand name would be Tylenol, Advil, things like that, those names that we know well, right? Okay. Prozac would be the brand name, fluoxetine would be the generic name, all right? Now, when we talk about drugs, we talk about them in categories. We have our stimulants, they produce wakefulness, a sense of energy. Our depressants that slow nervous system activity, okay? Not necessarily make you feel depressed, but depress meaning slow your breathing, your heart rate, things like that. And then we have opioids. These are our narcotic medications. They just typically reduce pain. We have our hallucinogens, our classic hallucinogens, and then some of the others that produce altered perceptions, okay? And then we have what we call our psychotherapeutics. These treat symptoms of mental disorders, okay? Some of these drugs belong in multiple categories, like marijuana doesn't really fit one of these categories. Nicotine is something we call biphasic. We'll talk more about that later. But typically, so nicotine has stimulant and depressant effects. Here's just a different way to kind of look at these classifications. Okay, so it's important for us to be able to identify drugs when we see them, right, to figure out what is this. Now, legal and illegal drugs do specific things on their pills or such to make sure that you can identify what it is if you find it. So we have something called the PDR, or the Physician's Desk Reference. We used to keep it around as a book. I am sure there are plenty of, computerized versions now. But within this book, you have all the different medications, and it would list all of the information about it as well as a picture of the pill. So that if you found a random pill, you could say, okay, what is this, and find a picture of it. All right. Now, some illegal drugs, MDMA, which is ecstasy, tends to have pills that all look different, like, a little alligator on it, have a little elephant on it, whatever it is, with the idea that the person taking it then kind of knows what type of ecstasy it is. Let's be clear, though, it's still made by somebody you probably don't know, and although it has a picture on it, you still don't actually know what's in it. You can hope you know what's in it, but you don't. The FDA regulates that the other medications do have exactly in it what they say it will. Okay. Drugs, of course, can be tested and identified through chemical analysis, too. All right. So when we talk about drug effects, we talk about non-specific effects and then specific effects. Okay, our non-specific effects are going to include our placebo effects. All right, these non-specific things are not exactly what the drug is doing, but based on like your background, meaning have you taken it a lot before or not? What are your expectations of taking this drug? What are your perceptions, your environment? Often if people feel anxious before taking a hallucinogen, it may go poorly. If they feel calm and ready, it may go well. If you drank a lot in the past and you drink, you probably don't get too drunk. If you haven't drank a lot in the past and you drink that much, you get wasted. Okay, so there's those. Then there's our placebo effects, right? A placebo is most easily described as if we think about a sugar pill, right? So when drug companies are doing testing, they give some people the actual drug and other people a placebo or a sugar pill that looks exactly like the drug. Then we can find out if there are effects. Placebo effects are really strong. So if you tell somebody something's going to work and you give it to them, it often works. Okay? If you tell people about all the side effects, they're much more likely to experience the side effects than if they weren't told about them. Sometimes when they're told about the side effects and they're given a placebo, they still experience the side effects even though they're not even having the drug. Okay? When we talk about placebo effects, we also talk about like alcohol studies, right? And this would be the things that you expect. So when you drink alcohol, you expect yourself to get louder, you expect yourself to get kind of whatever, not be able to stand so well and all this. So when they do these studies where they give people not alcohol, but people think it's alcohol, they end up seeing those same kind of effects from people. They act ridiculous, or they act like they think they would if they had been drinking. Okay. Now our specific effects are things that actually depend on the presence of the chemical at certain concentrations. Tylenol at a certain concentration will take away your headache. You know, other drugs will do certain things at certain concentrations. Okay. The double-blind procedure. Okay, so if I go in as a participant or a subject in a drug study, I am randomly assigned to either be in the group where I get the actual drug or the control group where I'm getting the placebo pill. Okay? They don't want me to know which I'm getting, or else we wouldn't know for sure if the drug is working better than nothing. Sometimes just going in and the placebo effects make it work, right? We want to make sure that the actual drug is doing something above and beyond just coming in and thinking something's going to work, right? Now, there's that. Double-blind means that the person that sits with me in the office, whether that's the nurse or the physician or whoever it is, also does not know if I am getting the placebo or the actual drug. Okay, so the reason we do this is because we don't want these, other non-specific effects to cause changes. So if the physician knows who's getting the drug and who's not, they may see people and act a little bit differently if they know it's somebody who's getting the drug versus act differently if they know it's somebody who's just getting the placebo anyway, right? They can try their best not to show it, but they might, okay? So the best kind of experimental controls would be that the person does not know and the physician or whoever is seeing that person and interacting with them also does not know. There's some sort of like research coordinator who does know, but that research coordinator never interacts with the people who are in the study, okay? So the double-blind procedure is the best way to control experiments, okay? It controls for non-specific effects. All right. So much terminology, I know. Okay, dose response curve. So the dose response curve is going to be a graph depicting the relationship between the range of a drug's dose and the resulting drug effects. Okay, so that is, as it increases, what type of effects do we get? Right? Now the threshold is the lowest dose at which an effect is observed. For a lot of drugs, you can kind of take them and you don't notice anything, and then you do. And then you notice more from there on. So that threshold will be the lowest dose at which an effect is observed. Okay? Different dose response curves can be created for different drugs. So we can see sort of the changes that might happen for different drugs at different times. Here's an example here. So this would be the dose of alcohol and the percentage of individuals showing the effect. And then we're looking at the dose response curves for slowed reaction time, for ataxia, and for coma. Okay? And we can kind of see how those changes happen based on the dose of alcohol. And how then at what point people start to notice it, and at what point people have really, obviously, are having some problems with it. Okay. So then we have something called a safety margin. The safety margin is the difference between the dose that produces the desired therapeutic effect, right? Not the threshold, but the desired therapeutic effect in most patients, and the lowest dose that produces unacceptable toxic reactions, whatever that means to people, okay? So you can imagine we want a wide safety margin. You want where the therapeutic effect is to be far away from the amount that might kill you, right? If you had this safety margin like this, it would be really easy to overdose, right? I have to take this much to make it work, but if I take this much, it might kill me. We want to make sure it's this way, so therefore we're less likely to overdose. Okay, wide safety margin would be good. Okay. The word potency. The potency is the amount of drug required to produce a given effect. Okay, so some drugs are more potent than other drugs. So like, as far as pain medications, opioids are much more potent than, let's say, a Tylenol or ibuprofen, okay? Side effects are just the other stuff that come along with what is intended. So we intend for our therapeutic effect, and then there are just these other things that end up coming along with it, okay? Now, our effective dose, okay, this is similar to our safety margin, right? So our effective dose, or our ED50, is the effective dose for half the animals in a drug test. That effective dose is the dose of the drug that produces a meaningful effect in some percentage of the subject. So ED50 is usually what we look at. Now the lethal dose would be the dose that will kill people. So the LD50 is the lethal dose for half the animals in a drug test. Okay? So similar to like when we talk about safety margin, the therapeutic index. Okay? The therapeutic index is going to be the lethal dose over the effective dose, or the LD50 over the ED50. It should always be greater than 1. Right? Always be greater than 1. If it wasn't, it would kill people before it worked. Clearly that's not going to work out well, right? Most drugs have an LD1 well above the ED95, meaning a wide safety margin. Okay. Now, we have time-dependent factors. So the time course of a drug depends on how it's administered. Is it smoked? Is it ingested? Is it shot in your arm? How rapidly is it absorbed? Again, that typically has to do with like Does it have to go through membranes? Does it have to go through the stomach lining? Does it just go straight past the blood-brain barrier? And then also, how is it eliminated from the body? Do we breathe it out? Do we sweat it out? Do we pee it out? How's it getting out? Now, drug effects can be prolonged, of course, by taking additional doses at specific time intervals. Like your doctor might say, take ibuprofen, once every 6 hours, or whatever it is. Intervals between different drugs do vary. Multiple doses too close together can increase that maximum blood level, okay? And then possibly leading to what you call cumulative effects. Cumulative effects would be taking too much of the drug too soon. So you still have this in here, and now you're adding this onto it. They can be negative, okay? This is just different routes of administration: oral, insufflation, IV, subcutaneous, and inhaling. Okay, so the first is that oral administration. It's pretty slow. It's the most complicated way into the bloodstream, right? It has to withstand the digestive process. It has to pass through the cell lining, into the GI tract, into the bloodstream, right? Drugs then pass through the liver, where they are metabolized. Okay, this is a very complicated way to get drugs in. It's a very common way to get drugs in, though. Okay, and then we have snorting, basically, insufflation. And this is rapid onset effects because you're going through the mucous membranes, basically. So it bypasses the liver, no first pass metabolism. We're just getting kind of through the mucous membranes, right on in there. We have IV injection, right? So typically we're talking about, people often think of like heroin. People inject lots of different drugs in the hospital and out of the hospital. Excuse me. There is a rapid onset of effects because you are putting it right into your bloodstream. High concentrations that can be delivered, which can be positive or not, right? So it can be positive when we're talking about trying to do surgery and things like that. It can be negative if you accidentally put way too much in or a little too much in because it's going directly to your bloodstream. Also, you may inject irritating materials. And veins do become damaged over time. So people that have used IVs a lot, or not IVs, but inject into their veins often, those veins kind of stop working, and then they have to use another vein and another vein and another vein. I've had a client who used to have to get into the bathtub in order to inject heroin into veins that you don't want to know about. You can use your imagination, but none of the veins that were accessible worked anymore. She had to get into a warm bathtub also to make veins open up enough. Also, of course, you have to worry about bloodborne diseases because you are putting possibly dirty needles into your bloodstream. Okay. There's also subcutaneous injection, okay? Now, I won't pull it up because some people don't like looking at this, but there's subcutaneous injection, and that would be right under the skin, okay? And some people call it skin popping that happens right under the skin. And it can cause something called necrosis. If you are interested, please do, Google images, skin popping, or necrosis. I think it's interesting information, but if you are someone who is weak of stomach, don't do that. You'll live a long time without seeing it. But it's interesting just to learn about other ways people get drugs into their system. And then you have intramuscular injection, right? And that would be into like a muscle typically. We do that with vaccines, right? The absorption is more rapid from intramuscular injection due to like greater blood supply in the muscles rather than the subcutaneous injection. And then, of course, inhaling things, right? We have rapid onset if you inhale. The drug moves from the lungs into the bloodstream through the capillary walls. It moves quickly to the brain. Okay, now, once in the blood, the drug molecules attach to protein molecules. The drug's inactive in this state. It can't be metabolized. You have these free, unbound drug molecules that move to sites of action in the body. And the drug is active then, okay? Drugs seem to vary for their liking for binding with different plasma proteins. Okay, so for a drug with high affinity, will displace a drug with low affinity. If you want to know more about this stuff, do look it up, read about it in your book. Okay. And then we have what we call that blood-brain barrier, right? In general, only like small, what we call lipophilic or lipid-soluble substances enter the brain. Heroin is more lipophilic than morphine. Therefore, we call it more potent than morphine, more intense than morphine, okay? Many brain capillaries are covered with those glial cells. Also increases the difficulty for compounds to pass out of the capillaries. We have these active transport systems that may be needed to move chemicals in and out of the brain. Okay, so there's these systems here. Trauma, infections, things like that can impair the blood-brain barrier, which can cause other problems because other chemicals can then get into the brain that maybe should not be in the brain. All right. We have effects on the specific neurotransmitter system. Okay, so drugs may alter the availability of neurotransmitters. And they may do, I mean, the thing is they do so many different things and it depends on the drug, but it changes the rate of like synthesis, metabolism, release, uptake, reuptake, and they may activate or prevent the activation of a receptor. With each drug that we talk about, we will talk about what it does. Okay? Then you have combinations of things. Be very careful. Do not combine alcohol and other depressants. It can cause respiratory depression, intense, severe respiratory depression, meaning you will not be breathing anymore. Okay? Combining stimulants and depressants have these complicated interactions, okay? And it's different with different types of things. So you can kind of see the different interactions that can occur. And again, we will talk about some of those with the specific drugs, but it's complicated. Okay, drug deactivation. So a drug ceases to have an effect when it's excreted unchanged from the body, like breathing it out, sweating it out, or it's chemically changed in the body. Okay. Most important drug metabolizing liver enzymes are our CYP450 group of enzymes. They are specialized for inactivating various chemicals. Also, many drugs have what we call these active metabolites. Look that up. Marijuana, diazepam have sort of their own active metabolites to break them down. Okay, when the body self-detects the presence of a foreign drug, they trigger the production of more of that specific metabolizing enzyme. This is when we talk about tolerance, because if that drug is there, then the body continues to produce more of it, and then it starts to think, well, that's actually normal, and that's just how it functions. And then when you have it gone, your body has to sort of adjust from there, and then it's very confused, and it can cause problems, okay? Interactions of drugs broken down by the same enzyme can be a problem, but also an issue then for tolerance. So if your body's already doing this and then you put in a different drug besides this one and you want it to have a different effect, but your body's already used to having it and producing this, then that drug will not have its effect. This can be a problem if you have pain, but your body's already used to producing metabolites for a different type of pain medication or a different type of thing that has similar action or activity, and therefore the medications will not work. Okay, last few things here. Drug disposition, and that's what we call a pharmacokinetic tolerance. This is increased metabolism or excretion, reduces the effect of subsequent doses. Okay? It may relate to like enzyme activity or alteration of the urine, the pH balance in your urine. We have behavioral tolerance, and that is that the user learns to compensate. So whether that's, you smoke marijuana all the time so often that that's just the way you function, or you drink alcohol all the time and that's just the way you function. And people may or may not know when you're using and when you're not using because you've learned how to compensate with that substance in your body. Then we have our pharmacodynamic tolerance, okay? And that's the sensitivity of the neurons. And that may change after repeated drug use. So they're so used to it that the sensitivity changes. And that can also cause withdrawal symptoms, okay? This chapter was full of a lot of vocabulary. I'd recommend going back through it. Remember, you do have access to these PowerPoints if you go to, I think it's Files, and then there's a folder that says PowerPoints, and they're all in there. Or you can kind of watch this again. You can go through it. You can turn the volume off, whatever you want to do. If things don't make sense, as I said, as always, look them up in your book. Okay, starting in the next chapter, we're going to be talking about more specific drugs. I think we start with stimulants or depressants. All right, I will see you then.